Hello, and welcome to Working with Treatment Services Children Training. This is an annual training provided by Pathways Youth and Family Services. Before we begin, make sure that you get with your Pathways staff member that you're currently working with, whether that's a Pathways home developer or a Pathways family specialist, to ensure that you have the correct test that matches this training. As we go throughout the training, if you get lost, you can always stop and rewind or fast forward or start the training over again to make sure that you get the correct answers. Not only that, there are some links on here for different websites, and so that you can copy those down as well so that you can utilize them. So let's begin. The purpose of today's training is to educate foster parents and staff about the types of treatment services as defined by residential child care regulations, training requirements, and available supports and services to families and children. What types of services does licensing regulate? There's two different types of services that licensing regulates when it comes to our foster families. The first one we're going to talk about is child care services. This is probably about 80% of the current licensed families with the Pathways Youth and Family Services Agency. For a child care services family, this means it's for services that meet a child's basic need for shelter, nutrition, clothing, nurture, socialization, interpersonal skills, care for personal health and hygiene, supervision, education, and service planning. Then we also have treatment services. And this is an addition to child care services as a specialized type of child care services designated to treat or support children. With the types of treatment services, we have 5 different types of treatment services criteria. Those are emotionally disturbed, which we refer to as ED, intellectually disabled, which is ID. Formally, if you're an older foster parent, if you look on your license, it may still say MR. On your license, it used to be called mental retardation. This changed a few years ago to where now that is labeled as intellectual disability. Autism spectrum disorder. Again, if you have an older license, this was changed a few years ago. It used to be PDD, which stood for pervasive developmental delay, but now it is autism spectrum disorder. And primary medical needs, which we refer to commonly as PMN for short. These are children with complex medical needs, and then trafficking victim. Those are the 5 different types of treatment services. The first one we're going to kind of go in depth about is emotionally disturbed. With our emotionally disturbed children, this is the most common type of treatment services we see with children across the state. These are children with emotional disorders who have a current DSM-5 diagnosis, such as mood disorder, psychotic disorder, dissociative disorder, or demonstrate 2 or more of the following: a major self-injurious action, including a suicide attempt within the last 12 months, difficulties that present as a significant risk of harm to others, including frequent or unpredictable physical aggression, an additional DSM-5 diagnosis of substance-related or addictive disorder with severe impairment. So majority of our kids in foster care, when you're reading that psychological evaluation, towards the very end of the psychological evaluation is where we're going to see those DSM diagnoses. A lot of our kids are going to have a psychological diagnosis. Just because they have a diagnosis does not make this child qualify for treatment services emotionally disturbed. They also have to have 2 or more of those other ones that we just reviewed there, those major self-injurious actions, significant risk of harm to themselves or others, and then that additional DSM-5 diagnosis of substance related or addictive disorder with severe impairment for them to meet that criteria for emotionally disturbed treatment services. Some helpful tips for emotionally disturbed children. Regarding subsection 2A, neither attending counseling nor taking a psychotropic medication factors into a child being eligible for treatment services for an emotional disorder. A lot of our children in foster care do attend counseling or skills streaming with a qualified mental health professional. They may also be prescribed a psychotropic medication for ADHD, depression, anxiety, mood stabilizer. Just because they are involved in counseling or prescribed a medication, again, does not make them a treatment services child. Only the indicators noted in that previous slide are considered when determining eligibility for treatment services. However, we may offer treatment services to a child who you assess as needing those services regardless of the indicators. So we can still offer children all the services that are needed for a treatment services child to any child in foster care, the counseling, the psychiatric care, all of those different types of things. Some common characteristics we see of emotionally disturbed children: unusual rage or anger, hyperactivity, they become irritated relatively quickly, immaturity, they're antisocial. But here's some that are a little bit more frequent. We may see fighting or cursing, stealing from others, destroying property, self-harm, harming others, lying, refusing to cooperate, power struggles between you and the child, physical aggression between the child and other children, or maybe between the child and adult, self-destructive behaviors or self-harm, suicidal behavior, runaways, psychiatric emergencies. These also could result in allegations or investigations of your home, a school suspension, a placement disruption. So we also got to take into consideration the risk to your family, yourselves, or children in the home, or as well as the community, the school that they go to, and those different types of things. So, and just because a child may have one of these things, again, does not make them treatment services. We have to go with those indicators that we just talked about 2 slides previously. We have intellectual disability. This was now referred to as ID and formerly referred to as MR. Again, with a DSM diagnosis of intellectual disability that's characterized by prominent severe deficits with pervasive impairment in one or more of the following areas. Now, with emotionally disturbed, remember we had to have 3 things on that list, that DSM diagnosis as well as one of those 3 things that was listed after that. For intellectual disability or autism spectrum disorder, we only need one of these things to be considered as intellectual disability. So that can be conceptual, social, and practical adaptive skills to include daily living and self-care, communication, cognition, or expressions of affect, self-care activities or participation in social activities, responding appropriately to an emergency, multiple physical disabilities, including sensory impairments. So that's what we would be looking for a child that falls into the intellectual disability treatment services criteria. Some common signs that we may see with intellectual disability in kids: trouble with logical thinking or inability to solve simple problems, inability to learn new skills despite prolonged practice. That may be dressing themselves, tying their shoes, something very simple that we may think of as a day-to-day task, but it's taking this child longer to learn. Behavioral problems such as poor tolerance and explosive tantrums, delayed development in areas such as crawling, sitting, walking, and talking, inability to understand social rules and customs, lack of curiosity or interest, or difficulty in remembering things. So some helpful tips for our intellectual disability children regarding subsection 2B, the previous slide, as a DSM-5 diagnosis of intellectual disability also requires a severity level of mild, moderate, severe, or profound. If a severity level is provided, the severity information may be helpful in determining whether the child is characterized as prominent severe deficits and pervasive impairment. So here's a helpful little guide here to kind of help guide you through if it's mild, moderate, severe, or profound. With mild, 85% of the ID population falls into this category. This can generally, they can learn reading, writing, math skills between the 3rd to 6th grade level. They may have jobs and be able to live independently. For moderate, this is 10% of our ID population. They may be able to learn some basic in reading and writing skills, able to learn functional skills such as safety and self-help. They may require some type of oversight or supervision to where an adult or person, a caregiver, is going to always have to be around to help them. The severe is 5% of our ID population. These children probably are not going to be able to read or write, although they may learn self-help skills and routines, such as dressing themselves, maybe even making themselves a sandwich or something of that nature, being able to use the microwave, require supervision in their daily activities and living environment. So they're going to need somebody that helps them with those routines throughout the day. Then we have profound, which is 1% of the population. This requires intensive support. They may be able to communicate by verbal or other means, such as sign language. They may have medical conditions that require ongoing nursing or therapy. So that person is going to have 24-hour care for profound. Autism spectrum disorder. This is very similar to intellectual disability. Now, we also used to refer to this as PDD, which was pervasive developmental delay. With a DSM-5 diagnosis of autism spectrum disorder that's characterized by prominent severe deficits and pervasive impairment in one or more of the following areas, again, matches intellectual disability, conceptual, social, and practical adaptive skills to include daily living and self-care, communication, cognition, and expressions of affect, self-care activities or participate in social activities, responding appropriately to an emergency, multiple physical disabilities, including sensory impairment. Kids on the autism spectrum disorder, some things that we may notice with them. They have developmental coordination disorder, oppositional defiant disorder, ADHD, Tourette's, anxiety, OCD, sensory integration disorder. Some of these kids, we may also classify them as gifted as well. So with some helpful tips for our autism spectrum disorder, ASD, regarding subsection 2C, the slide 2 slides ago, the autism spectrum disorder includes previous DSM-4 diagnosis of autistic disorder, Asperger's disorder, pervasive developmental disorder, not otherwise specified, or similar disorders associated with a known medical or genetic disorder, such as Rett's disorder. Now, a couple of years ago, they did away with Asperger's and pervasive developmental delay. So if you read a current psychological evaluation, they will diagnose the child now with autism spectrum disorder, and then they can classify that as mild, moderate, or severe. For a child that is a mild autism spectrum disorder is what we used to refer to as Asperger's, if that's any helpful tip for you. The newly titled disorder is a single continuum of mild to severe, a level 1 through 3, impairments in 2 domains of social communication, and restrictive repetitive behaviors and interests. A DSM-5 diagnosis does not mandate a severity level. However, if a severity level is provided, then the severity information may be helpful in determining whether the child is characterized by prominent severe deficits and pervasive impairment. Again, when we're looking at that level 1, 2, and 3 on that autism spectrum disorder, a level 1 is high functioning autism. Like I said, this was what we used to refer to as Asperger's. They require some support. They have difficulty initiating social interactions, carrying on a conversation with another person, making small talk, inflexibility of behavior, difficulty switching activities, and problems with organization. For a child that is level 2 autism, we're going to see requiring substantial support, marked deficits with social interactions, inflexibility of behavior, difficulty or distress coping with change, repetitive behaviors. Level 3, we're going to see severe autism. This requires substantial support, severe deficits with social interactions and communication. Some children on the level 3 severe autism cannot verbally communicate. They may be able to communicate using sign language or using a device to help them to communicate, like an iPad or something of that nature. And flexibility of behavior, extreme difficulty or distress coping with change, repetitive behaviors interfering with function. We have primary medical needs, or PMN for short. A child with primary medical needs is going to be a child who cannot live without mechanical supports or services of others because of life-threatening conditions. Now, these are going to include the inability to maintain an open airway without assistance. That's going to be a trach, is where we'll see that, where that child has to breathe, the assistance of breathing through a trach to help them breathe. They're probably going to have to be fed through a G button that goes inserted directly into their intestine because they don't have that ability to swallow. Now, this open airway does not include the use of inhalers or asthma. If you have an asthmatic child that needs an inhaler as an as-needed basis, if they're having difficulty with breathing, that does not classify as primary medical needs. Open airway, that's going to be a trach in the child's neck. Or not neck, but their esophagus. The inability to be fed except through a feeding tube, gastric tube, or parenteral route. I can never say the word. I apologize for that. But that's going to be where that G button goes directly into the child's intestine, and the formula is inserted then through the tube into the intestine for direct nourishment to the child. The use of sterile techniques or specialized procedures to promote healing, prevent infection, prevent cross-infection or contamination, or prevent tissue breakdown. This could be a child with severe burns. Some of our medically fragile children are fed through what's called TPN, and the TPN line goes directly into their heart. And that has to be covered at all times when they're changing the dressing. If they were to reach over that site to grab a gauze pad or something, that would be considered cross-contamination, reaching over that site. Multiple physical disabilities, including sensory impairments. So again, any of those types of things will help us to diagnose and classify that child as a primary medical needs treatment services criteria. And then our last one is trafficking victim. This one was just added about a year or so ago. For a child to be classified as trafficking victim, they have to be determined to be a trafficking victim as the result of a criminal prosecution or who is currently alleged to be a trafficking victim in a pending criminal investigation. Law enforcement is already involved in this case. Identified by the parent or agency, and the agency would be CPS, that the child with the child placing agency is a trafficking victim. So that's how we would know if that child was a trafficking victim, is they're identified by the parent or CPS whenever they're seeking placement for that child. Determined by the child placing agency, which would be Pathways, to be a trafficking victim based on reasonably reliable criteria, including one of the following. So the child's disclosure as a trafficking victim, the assessment of a counselor or other professional, or evidence that the child was recruited, harbored, transported, provided to another person, or obtained for the purpose of forced labor or commercial sexual activity. So if we have any of those three things, then we can then classify that child as a trafficking victim. What are the qualifications to become a treatment services foster parent? If this is something you're thinking about, or you have a child that you've identified that you would like to work with that's considered treatment services, these are the things that have to be completed. A person has to have 40 hours of supervised observation with a foster family caring for this population of child or relevant life experience. So if you were thinking, wow, I would really love to be able to help children on autism spectrum disorder, but you have no history of ever working with a child with autism spectrum disorder, you would have to do 40 hours of supervised observation in a foster home with children who, with a family who fosters children with autism spectrum disorder that is treatment services. And then we would log those hours in to complete those 40 hours of observation. You're going to also have to have 16 hours of behavior intervention the first year of fostering and 8 hours of behavior intervention on an annual basis. This also goes for your babysitters, respite providers, and caregivers. They have to follow the exact same criteria. Annual training for child care services families is 20 hours of training per year. And for treatment services families, it's 30 hours per parent. So we got to make sure that we're keeping you up to date on those training hours, as also required training as identified by residential child care regulations and contract standards. So annual training that you're going to be completing with Pathways, one of them is this class that you'll be doing on an annual basis, but that's going to include emergency behavior intervention, online DFPS training, which are normalcy, psychotropic medications, medical consent, trauma-informed care, reporting abuse neglect, and preventing and reporting child sexual abuse. Those are also due on an annual basis. There's also quarterly trainings that are conducted per calendar quarter, and there's 8 of those per year. Those will be switching to annually, and this is one of those. Those annual classes are instructor-led meds, cultural diversity, treatment services, working with treatment services children, human trafficking, water safety, disaster and emergency planning, reporting serious incidents, and I'm missing one. I knew I would do that, but that will give you some idea. Those are required on an annual basis that you'll have to do those. And then also CPR first aid as it expires. In most cases, CPR first aid is good for 2 years. So as that 2-year mark expires, you would then have to retake the class. Training that is also relevant to the treatment services child you're providing care for. Let's say you're a medically fragile foster parent, primary medical needs, PMN. If you're working with a nursing agency and they're teaching you how to clean around the wound site of the G button and replace any type of equipment, that could be ongoing education for treatment services medically fragile, autism spectrum disorder, intellectual disability, emotionally disturbed, whatever each type of treatment services that you are licensed for, you will need training specific for kids in that. For an emotionally disturbed child, that could be training on different types of psychological disorders, medications, therapies, services offered within the school district. It could be a variety of things. So each one of those treatment services has to have specific training. Pathways service plans. Pathways has to develop a service plan within 21 to 30 days after the child is placed in the Pathways foster home, depending on the region in which the child is removed. The first time we place a child with you, this is going to be the most that you will see us at your home. When Pathways comes out to do the placement, you'll see us at placement. We also have to do what's called a 7-day contact of 7 days from the date of that placement. And then you're going to see us again for that service plan meeting. So that you'll see us 3 times that first month that a child is placed in your home. The service plan must be based on the child's identified needs and integrates trauma-informed care in the care, treatment, and management of each child. When we're putting that service plan together, we're going to be targeting these different things we're about to address. The child's needs identified in the admission assessment, in addition to basic needs related to day-to-day care and development of the child, including medical needs, dental needs, intellectual functioning, developmental functioning, educational needs, plans for normalcy, therapeutic needs, and cultural identity needs. We're going to have to go through each section of the service plan and identify those that we just covered, as well as specific goals and strategies to meet the child's needs, including instructions to caregivers responsible for the care of the child. Instructions must include specific information about the child's personal trauma history, their level of supervision, trauma triggers, discipline, behavior intervention, maintaining relationships with the family, caregivers evaluation, and a variety of other factors pertinent to the day-to-day care of the functioning of the child. So with supervision, remember there are different types of supervision. There's insight and alone time. For most of our children, there's insight or within earshot, knowing that that child is safe. As children get older, teenagers, for instance, that is where we can start looking at alone time, where that child can come home from school for an hour by themselves. Or if you're going to the grocery store and they don't want to go, maybe they can stay home alone. But that has to be addressed in the service plan and approved by CPS for us to be able to do that. So who's going to participate in that service plan? The child, if they're verbally and developmentally capable of participating, they need to be in that. They're 4 or 5 years old. Now, where they're not going to sit at the table the whole time with us and go through all of those different things that we're addressing during the service plan, but we may ask them very simple questions like, if you could be involved in any activity, what would it be? Baseball, Boy Scouts, Girl Scouts, cheerleading, gymnastics, 4-H, whatever it is that that child's interest may be in. We can help them. They can help us to identify maybe some household rules, consequences, and rewards. We can ask them things about their culture. How did they say prayers before they went to bed at night? How did they celebrate birthdays? What holidays did they celebrate? Those different types of things. So we can add those cultural things into the cultural section of that service plan. But also, the people that are going to participate is the caregiver, which is you, the foster parent, the therapist, the Pathways family specialist, the MOSAIC qualified mental health professional, PMN treatment director if we have a child that is medically fragile, and the CPS worker or the SSCC worker. That stands for Single Source Continuum Contract Worker. Service plans are reviewed every 6 months for children who are at basic, moderate, or standard level of care. But they're reviewed every 3 months for children who are considered specialized, intense, therapeutic, or therapeutic 2. Then we're going to be reviewing those every 3 months. With the service levels, children in foster care are assigned a level of care based on their needs. For regions in Texas who have not privatized into a single source continuum contract, they're going to be evaluated by Youth for Tomorrow. For the SSCC regions, which are regions 1, 2, 3B, 4, and 8B, the reviews are conducted through their own processes. Children who are moderate or therapeutic are reviewed on an annual basis by Youth for Tomorrow or through their own processes. Children who are specialized, intense, or therapeutic 2 are reviewed every 3 months by Youth for Tomorrow or through that SSCC's individual basis that they base that on. So what information is reviewed? What do they look at when they're trying to determine a child's level of care? The information needed and reviewed as part of the service level includes the most recent 30 days of foster parent notes, medication logs, the doctor dental forms, Pathways family specialist notes, therapy notes, which can include occupational therapy, speech therapy, physical therapy, and individual therapy, as well as the service plan, school reports, and the psychological evaluation. Maintaining foster parent documentation is not only a residential child care regulation standard, but it's also crucial in planning for the child's treatment. When we're looking at those different levels of care, and you can find this on the Youth for Tomorrow website, the child, for a basic level of care, the child needing basic services is capable of responding to limit setting or other interventions used as a normal family setting, The characteristics of the child may include transient difficulties and occasional misbehavior, acting out in response to stress, but episodes of acting out are very brief, or the child is easily redirected or calmed down. The behavior is minimally disturbing to others, but the behavior is considered typical for that child's age and can be corrected. The characteristics of a child with developmental delays or mental retardation may include minor to moderate difficulties with conceptual, social, and practical adaptive skills. Now, guys, what you also have to remember is we're not comparing this child to a child that is raised in a nurturing home environment, that has been giving all the resources, that knows how to self-regulate and have had a different way of living role modeled for them. When we're saying a child has a basic level of need, we're also comparing them to other foster children who also come from a trauma history, that have endured some type of abuse or neglect and have some type of probably psychological diagnosis. So that's what we're comparing them there to. For a child who has a moderate level of care, child needing moderate services has problems in one or more of the areas of functioning. The characteristics of the child may include frequent, nonviolent, antisocial acts, occasional physical aggression, minor self-injurious actions, difficulties that present a moderate risk of harm to self or others, The characteristics of a child who abuses alcohol, drugs, or other conscious altering substances may include substance abuse to the extent or frequency that the child is at risk of substantial problems, and a historical diagnosis of substance abuse or dependency with a need for regular community support through groups or similar interventions. Also, we will continue to see with child with a moderate level of care. Characteristics of a child with developmental delays or mental retardation may include moderate to substantial difficulties with conceptual, social, and practical adaptive skills to include daily living and self-care, moderate impairment with communication, cognition, or expressions of affect. The characteristics of a child with primary medical or habilitative needs may include occasional exacerbations or intermittent interventions in relation to the diagnosed medical condition, limited daily living and self-care skills, ambulatory with assistance, and daily access to on-call medically skilled caregivers. So that's going to help us in determining what meets that moderate level of care definition. And then for specialized, the child needing specialized services have severe problems in one or more of the areas of functioning. The characteristics of the child may include unpredictable, nonviolent antisocial acts, frequent or unpredictable physical aggression, being markedly withdrawn and isolated, major self-injurious actions to include recent suicide attempts and difficulties that present a significant risk of harm to self or others. So that kind of gives you an idea. Again, if you Google Youth for Tomorrow Texas, you can go to their website and it will outline those again for you. Jumping into school planning, ARD meetings, IEPs, all of those kind of fun things that you may have never heard of before, especially if you've never worked with a child with special needs. Support through the school district. When we're looking at support through the school district, we will look at the first thing is called an ARD meeting, A-R-D. This is an acronym for Admission, Review, and Dismissal. An ARD meeting is a meeting of a group of people who help to determine whether or not a student is eligible for special education and develops the individual education plan, also referred to as an IEP, for eligible students. This is a foster parent's right as they are the educational consentor. When a child is placed in your home, there's going to be a variety of different types of authorizations that you sign. One of those is the educational consentor. That gives you the right as the foster parent to be able to request testing for the child, request an ARD meeting, and be involved in the planning for that child. This is a foster parent's right. I just said that. This form is signed at placement and provided by CPS. First, an evaluation has to be requested through the school district. Ask your child's teacher who the contact for the school is, and then they can provide you the form if a letter of request is required. Every school is a little bit different. Even within a school district, every campus may function a little bit differently. So one campus may say that it's a formal request. There's a very specific form that you have to fill out and submit. Another campus may say it just has to be in writing. If you put it in an email format, that is a form of writing. And then other ones, it may just be a simple request to the teacher or the school counselor for that initial testing. Once they've completed that initial testing, from that, we can then request an ARD meeting. You can always go to the website of your school district, and they should have this information on there as well if you want to look it up and be fluent in what those protocols are. So what is the purpose of an ARD? An ARD meetings are meant to help and identify a child's educational need and how to meet it. There are different types of educational services children can qualify for. Special education, this is a means specifically designed instruction at no cost to the parent to meet the unique needs of a child with a disability, including instruction conducted in the classroom, in the home, and hospitals, institutions, and other settings. So not only is this for a child in the foster home setting, this could be for a child in a shelter, a residential facility, a child that's in a psychiatric hospital, or a child that maybe has some type of illness, like going through cancer treatments where they're hospitalized. It can still take place in the hospital. That's special education. Then we have 504 accommodation plan. This used to be referred to as content mastery. So the 504 accommodation plan is guided by the Americans with Disability Act, the ADA, to ensure that a student with a disability has access to accommodations that improve academic functioning. In order to qualify for a 504 plan, a student must have a diagnosis for a physical or emotional disability or impairment. Example would be ADHD that restricts one or the more major life activities, like paying attention in class, being able to participate in class. This is where it's very important that we do get the psychological or developmental evaluation performed on all of our kids in foster care so that it helps with all the treatment planning, whether that's therapy or an ARD meeting. We can share this with the school district. Now, whenever a child has a psychological evaluation performed, in that psychological, somewhere in there, it's probably going to talk about why the child was removed from the family and that kind of stuff. If we're going to provide this to the school district, I would recommend taking that page out because that's really nobody's business. We want to maintain that child's privacy, but we do want the school district to be aware of what those diagnoses are, any type of behaviors that that child may have, and so on, so that we can help that in putting together the individual education plan during the ARD meeting. Individual education plan. This is an individual education plan or program that is also known as an IEP. This is a plan developed to ensure that a child with an identified disability who is attending an elementary or secondary education institution receives specialized instruction and related services. So who's involved in that IEP planning? The special education department, school counselor, the foster or adoptive parent or kinship caregiver, a general education teacher, as well as the CPS worker, pathways, CASA, who is the child's guardian ad litem, or the child's attorney, which is the attorney ad litem, can also attend that meeting. So this is where this IEP, this individual education plan, is going to take place during the ARD meeting. CPS support for education. In each region in Texas, we have an educational specialist. The CPS Regional Education Specialists help students in substitute care and are a resource to CPS staff, caregivers, and community stakeholders. They can attend ARD meetings, advocate for a child's individual education plan or behavior plan with the school district. So you can also find your local education specialist through that link that is provided there. If you go to the DFPS website, this is where you can also find that information as well. The education specialist is a very helpful tool for us, especially if you've never been in an ARD meeting before or been involved in an individual education plan. They can help us to advocate for those different goals and services. Now, not only do we ARD a child for learning disabilities or developmental delays, we can also ARD a child for behaviors. And this again is where that individual, that education specialist would come into play in helping us to advocate for those services for that child. Also through the school district. Each school district and open enrollment charter school in Texas is required to appoint at least one employee to act as a foster care liaison officer. The liaison facilitates the enrollment in or transfer to a public or open enrollment charter school of any child in the school district or area served by the school who is in the conservatorship of the state. So these people, their role is to help a foster child to enroll in their school or transfer from one school district to another. The 83rd Texas legislative session added open enrollment charter schools to an existing law that required districts to designate foster care liaisons. Additionally, both districts and charter schools must submit their foster care liaison's name and contact information to TEA, which is the Texas Education Agency. Superior Medicaid. Superior Health Plan is Texas' only provider of health services to children and youth in foster care. Under a contract with the Texas Health and Human Services Commission, they work with clinics and hospitals statewide to ensure every child has access to essential care, including primary care providers, behavioral health specialists, and vision services. Foster parents can locate local providers by following the web link provided. Again, if you go to fostercaretx.com, it's going to immediately take you to their general page. There's one for members. Your child and you are now a member of that. And you can click on find a provider. That provider, when you click on that, you can find not only a primary care physician, but also dental providers, vision providers, behavioral health, hospitals, and also pharmacies rather, that accept Superior Medicaid. If you're looking for a primary care physician, you can just type in your zip code. Once you type in your zip code, it's also going to narrow down what type of provider are you looking for. Are you looking for a primary care physician for a child, a pediatrician, a nurse practitioner? Like what exactly type of doctor you're looking for? It may be a specialist because your child broke their arm and now we need an orthopedic doctor. So it will help you to narrow that down. Once you hit search, it will then give you a list of people. In that list of providers, it will tell you if they're accepting new clients, their business hours, their contact information. It gives you a variety of information for them. So it is a very, very helpful tool. Superior Health numbers. If you also look on the back of your Superior Medicaid card, the child that's in your home, there are some numbers on there as well. But the Superior Member Services number is on there. Texas STAR Program Helpline, Medicaid Managed Care Helpline, Medicaid Managed Care TTY helpline, the NurseWise 24-hour helpline. This is a really good resource, guys. The NurseWise, if your child is having an adverse reaction to a medication, then this is definitely maybe one that you want to call if it's late at night and you know your doctor's office is closed. The NurseWise 24-hour helpline is answered by a registered nurse, and they'll be able to help answer those questions. Royalty Texas for the hearing impaired is on there as well. Pharmacy helpline for prescription drugs, medical transportation, eye care, dental care, behavioral health, which is Simpatico, alcohol and drug crisis line, and then connections to community services. So there's a lot of different services through Superior Medicaid that you can access. When we're looking at mental health, we do have mental health services. So this is a very good time to access those mental health services for children in care because they need them. 100% of our children entering the foster care system are coming from trauma. So this is the most crucial time to enact those mental health services with our kids so that they can develop resiliency as they go into adulthood. Your child is more than their mental health needs. Your child is a part of your family, a student at school, an important member of the community. They also have friends, hobbies, and interests. They are important to other people, and other people play an important role in their life. Teachers, friends, neighbors, relatives. Many children and youth experience life events, biological, environmental, and developmental changes that impact their mental health. Some experience changes in behavior, feelings, social relationships, and academic achievement in school. These changes should be a sign of the need for additional support or the need for mental health services. Having mental health needs is very common. National statistics show that 1 out of 4 children or youth will have a mental illness or serious emotional disturbance during childhood. Early identification and treatment increases resilience and the possibility of a prompt recovery. Formal supports, also known as services, address mental health needs and should help to develop natural supports and strengths. The more natural supports and strengths your child has, the less he or she will need formal supports. This, with a little help from us in the beginning, your child will be able to use their strengths and overcome challenges and adapt to stressful or life-changing situations across their entire lifetime. So I think it's very important, guys, that we do access those services now so that the kids can get the mental health services they need to, again, help them to be a functional, successful adult. With the different types of behavioral health services, we like to throw a lot of acronyms at you and just expect you to know what we're talking about. So some of the things that we talk about when we're talking about behavioral health services, one of those is the CANS assessment. You and your child will participate in an interview that uses a tool called the Child and Adolescent Needs and Strengths Assessment, named the CANS for short. This is a detailed assessment that helps identify all of your child's areas of need. The assessment is done between 90 days to annually to be aware of any changes that may have happened. This also helps track progress for your child that they've made towards the recovery, including the building of strengths, which are essential to developing the resilience they will need throughout life. This has to be completed within 21 to 30 days of children ages 3 and older being placed in your home who are new to foster care. And then this is also going to be done on a regular basis, annually in some circumstances, and others it may be every 60 to 90 days. A therapist. A therapist is a licensed mental health clinician who has also received training and therapies that help address emotional needs related to your child's mental health diagnosis. These are usually licensed professional counselors, LPCs, licensed clinical social workers, LCSW, or licensed marriage and family therapist, LMFT, among others. A qualified mental health professional. If you're working with our MOSAIC program, we commonly refer to this person as a behavioral health specialist, but the technical terminology is a qualified mental health professional, or a QMHP for short. This person has received special training in a variety of evidence-based practices that help address behavioral needs related to your child's mental health diagnosis. They are also trained to provide skills training curriculum that helps parents manage their children's mental health needs. So again, we throw that acronym at you a lot. Skills, they do skills training. They're doing skills with your child. So what is skills training? Skills training is used to address negative behaviors that are symptoms of emotional disturbance. Someone will work with your child to build skills that improve the ability to cope with your unique symptoms. These skills will help your child to function independently in school, at home, and in the community. Skills training is also available for parents. This goes beyond basic parenting techniques and is specifically designed to help parents address their children's mental health needs. So that's what skills training is. Then we also have a psychiatrist. A lot of people get a psychiatrist and a psychologist confused and may not know what the difference is between the two. A psychiatrist is a physician, a doctor, who specializes in psychiatry. He or she will assess for and provide a mental health diagnosis, prescribe medication, and provide psychoeducation. Children are usually seen by their psychiatrist every 30 to 60 days, but have to be seen at least every 90 days. So this person is the person that's prescribing a psychotropic medication, an antidepressant, mood stabilizer, ADHD medication. This person has to see that child at least every 30 to 60 days. And we've got to remember, children are growing, children are changing. Their body weight is changing, their height, the degree of the way their body is metabolizing those medications. So we got to make sure that they're being seen on a frequent basis to make sure that medication is maintaining its effectiveness and that there's no side effects that are happening or anything of that nature. Now, a psychologist. A psychologist is a person who studies normal and abnormal mental states, perceptual, cognitive, emotional, and social processes, and behavior by experimenting with and observing, interpreting, and recording how individuals relate to one another and their environments. Psychological evaluations are valid for 13 months. So a psychologist is who's going to do a psychological or developmental evaluation on your child, where we receive it that has all the information with their IQ scores, their psychological diagnosis, amongst a variety of other things. That's the psychologist. This is a person who has their doctorate in psychology, whereas a psychiatrist is a doctor, a physician who specializes in psychiatry. If a family's in crisis, we would like for you to call Turning Point. Turning Point is a crisis intervention, acute stabilization, and psychiatric diversion program that provides children and their caregivers with therapeutic services and natural supports to help prevent hospitalizations and maintain stable foster home placements. Licensed professionals are available 24 hours a day, 7 days a week to provide initial support, assessment, and service referrals over the phone. Additionally, mobile on-site crisis teams provide in-home intervention and safety planning are a part of that process. Um, Now, if you need Turning Point, they're only available through pathways in Harris County and Bexar County. But again, if you call the Superior Health Crisis Care Line, they're going to connect you with those services. So there's that number on there, 877-644-4517. They're 24 hours a day, 7 days a week. You also have what is called a local mental health authority, or an LMHA for short. If you or someone you know are faced with a mental health crisis, please call the crisis hotline of the local mental health or local behavioral health authority for your county. This can also be provided by dialing 211. They provide the same service as Turning Point. There are 254 counties in Texas, and there is a local mental health authority in every county to assist you. So not only can you call 211 and be connected immediately to that local mental health authority crisis hotline, but there's also a website here. If you follow this link, that will take you to those local mental health authorities if you wonder which one is assigned to your county. Services for children who are intellectually disabled, autism spectrum disorder, or primary medical needs. What those services are, one of them is home health care. Home health care includes skilled nursing care, as well as other skilled care services, such as physical and occupational therapy, speech therapy, and medical social services. These services are given by a variety of skilled healthcare professionals at home. The home healthcare staff provides and helps coordinate the care and therapy from the doctor's orders. Along with the doctor, home healthcare staff create a plan of care, which is a written plan of care for your child. It tells what services and goals that we're going to be able to reach through physical, mental, and social well-being. The home healthcare staff keeps your doctor up to date on how you're doing and updates the plan of care as needed, as authorized by the doctor. Occupational therapy, which is also commonly referred to as OT, is a treatment that works to improve fine and gross motor skills and motor planning. It can also help kids who struggle with self-regulation and sensory processing. The majority of our kids in foster care, guys, have sensory processing disorder, especially with our young children. If we have children who bite or who are very rough and they're constantly hurting themselves, they probably have sensory processing disorder. I would highly encourage you to have that child be assessed by an occupational therapist to see if they qualify for occupational therapy. Speech therapy, also referred to as ST, is an intervention service that focuses on improving a child's speech and abilities to understand and express language, including nonverbal language, as well as eating, drinking, or swallowing. So it's not just helping a child who has a speech impediment, but also children that are babies that are born that don't have the ability to latch to a bottle. Maybe they have an NG tube that goes through their nose and through their intestine. So a speech therapist works with that child to form the muscles in their mouth to help them latch to that nipple that also helps them to swallow. If we have a child that had a trach, that they were breathing through a trach and they had a G button, they've never been fed by mouth before. So a speech therapist will help that child with swallowing, whether that's food or drinking, whatever that may be. Physical therapy. Physical therapists work to decrease pain, improve movement, and help children return to daily activities. They teach children exercises designed to help them regain strength and range of motion. So that would be physical therapy as well. Occupational speech and physical therapy does require a doctor's order. Most of our pediatricians will write that order for you. They like to err on the side of caution. If the child is 0 to 3 years old, they can be seen by ECI, Early Childhood Intervention. That is a government agency that can come out and do the assessment and offer the services to the child. There are also many private agencies out there that will also do the assessment, submit that to Superior Medicaid for approval, and initiate those services. Now, our children 3 and older can also receive these services through the school district. I will tell you, through the school district, it is very limited. It may be once a month, it may be once a week. I would highly encourage through those individual agencies that are out there. They're a little more intensive in their services, like 2 to 3 days a week. And we're going to see a more rapid improvement in that child's abilities when we have that individual agency involved. So some resources that we use for this curriculum, one of them is minimum standards that we use for child placing agencies, the way we're regulated through residential child care regulations. I also looked through the Texas Education Agency. That's how I got a lot of the information for the school districts, and the Family Guide for Children's Mental Health Services, which is where I got some of the information for the mental health services portion of this training. Now, do make sure once you complete your test, you want to turn that into the Pathways staff member that you're working with. That if you're a licensed foster parent, that may be your Pathways family specialist, or if you're a new family that is going through the process, that may be your Pathways home developer. So you want to be able to submit that to them. They're going to grade it, upload it to your file, and you will also get a certificate for the training. If you have any questions, feel free to reach out to us and ask us for questions. If you need these sites, again, provided to you, we're more than welcome to do that. We're more than happy to provide that to you. But other than that, guys, that's all that I have for this training. Please reach out to us for any further clarification or questions. Have a great rest of the day, and please remember to turn that information into your Pathways staff member that you're working with. So thank you so much for joining, and we'll see you next time.